I want to delve into what this may mean for you in making your treatment decisions, also touching on new developments in melanoma research that you might want to keep in mind as you decide which treatments to pursue, and how some of these may be much closer to you than you think, and available right here close to home. I let myself be guided by these two questions when I put together the materials for this component of our talk. What are the new breakthroughs in melanoma research today? And what are my options when I might plan my treatment? We'll review some new diagnostic tools for treatment planning that were in use before and that are still being explored. There are numerous new discoveries that are taking melanoma care really to exciting places from bench to bedside. And even with the tools we have already, which Dr. Kawikansky discussed, there are novel treatment approaches to enhance the outcomes that we've already seen with the advances we've achieved. Along the way, I'll point out how some of those treatments might be available to you close to home. We'll start with diagnostic tools to consider when you're planning your treatment. And really, when you're trying to plan your treatment, you'll come across decision crossroads at multiple junctures in your care. Dr. Jones talked about several decision points in just your surgical planning. You can see from Dr. Kawikansky's talk, there are multiple things to think about in deciding what you may do after surgery. Do you need more treatment? And if you do, what type of treatment is the right treatment for you? And which drugs would work well for you? We're at an exciting point in the field because in the past, when we just had chemotherapies, the way we decided who was going to get what was really very random and decided by what hundreds or thousands of people before you did on a study of XY% difference. Since the Human Genome Project, we can have a little bit more information than that to help guide what we may want to do. We can assess your tumor features and plan your treatment based on that. Across the cancer field, we're looking at the tumor at the chromosome level, perhaps the environment of how the genes may interact with each other, pertinent these days is the tool of DNA sequencing and the information we gather from understanding better what your actionable mutations in your tumors may be. There are ongoing tumor sequencing initiatives. A lot of it has been accomplished in the last decade, and we've identified multiple driver genes now across multiple tumor types. In melanoma, we have a pretty good understanding of common active mutations that are generating a lot of the events that bring us here today. The most important one we've talked about is BRAF. Most common, 40 to 50% of patients has targeted drugs to intervene in this event. And some of you may have heard in your reports about NRAS mutations, that you may have a P10 mutation or a CDKN2A. We don't understand the significance of all of these yet and whether they may or may not be actionable, but even just having that understanding is opening more doors to find better therapies for us. And there are multiple sequencing assays available now, commercial and institutional. Many of you may have heard of Foundation One or Caris. Here at Kaiser Permanente, we have a unique relationship with Strata Oncology, and that is because it links directly to clinical trial participation. Some of these have FDA-approved indications for tumors that have treatment indications on the basis of genomic changes. And they all these days include anti-PD-L1 status, maybe tumor mutation burden, and I'll delve into it a little bit later. Here in the Bay Area, some of you may have heard of the UCSF 500 test that is offered at UCSF, which is an in-house test. And other institutions like Memorial Sloan Kettering or Dana-Farber have designed their own sequencing tools to better understand the tumors of patients that they're treating. There are other ways to look at genomic information. People look at gene expression assays. The way I would explain that is rather than looking at a specific change in a gene, you're looking at a family of genes that appear pertinent in the biology of your tumor. For melanoma, Castle Biosciences designed DecisionDx, which may be you've heard from other patient families with breast cancer, like an Oncotype DX that's used very commonly in breast cancer. At any rate, with this gene signatures, they propose that you could classify tumors who undergo sentinel lymph node biopsy, as Dr. Jones discussed, into those that are high risk or low risk for recurrence or distant metastasis down the road. We heard about tumors that have no lymph nodes currently, not necessarily being recommended to have systemic treatments, but we do know that some of those do have a high risk of relapse. So what should we do, and how would we know that even though you do not have a positive lymph node, that you have a higher relapse, and what should we do? So this is an exciting part, I think, that in the field right now that's getting a lot of research, and it'll go concurrently between planning treatment in this group as well as better understanding their biology. So how can you apply some of these tumor data that you're generating from these new diagnostic tools in your care planning? Many of you, if you have advanced melanoma, have heard about your BRAF or BRAF mutation status of your melanoma from your providers. If you happen to have a tumor with a BRAF mutation, you'll wonder whether you would want to start with the tablets that target this mutation that are available to you, or should you start with the immunotherapy Dr. Kawikansky discussed? So that's one decision point that you wouldn't be able to make if you didn't know your tumor mutation status. Furthermore, from the studies, we also know that perhaps 2 immunotherapy agents would be more beneficial to you if you have this mutation, as it ends up having often a more aggressive clinical outcome. The anti-PD-L1 expression is looking at how your tumor might respond to the checkpoint inhibitors that target PD-1. This is a test done on the tumor, but also offered now in a lot of these tumor sequencing assays that are available commercially. And if you have friends with other classes of tumors, it might be more pertinent to them, and you might have heard about that. In melanoma, it's less clear how immediately it might affect your treatment. Certainly, everyone would agree that it may predict how likely you will respond to treatment, meaning if it's a very high positivity, that you would respond better. It's been shown that it might help to decide whether you should just use one agent versus 2 agents. Many of you might have had that discussion with your providers. Should I start just with nivolumab or pembrolizumab, or should I do the combination of nivolumab and ipilimumab? And then the NGS sequencing. Understanding the biology of your tumor may help to open more doors for treatments after some of the standard treatment options, after you've tried some of the other standard treatment options. It might open novel doors and help better understand the biology of your tumor. Perhaps if you've had a BRAF mutation before, now perhaps your tumor has changed. So it's a very powerful tool to understand your tumor from the bottom up. In terms of new discoveries from bench to bedside, we have a lot of exciting developments in the melanoma field, and I won't be able to mention all of them. I've just picked a couple here that I think are relevant to some of the options you have within our program. One more novel immunotherapy agent is, I'll call it short TVEC. It's really a scientific achievement, something that was previously done only in the lab to modify a virus and change its biology, was used to understand tumor biology behavior. But here, people have used to elegantly design a treatment that uses your innate response to viruses and direct that towards the tumor. And so tumor cells rupture because of this response to the virus. And when tumor particles are then released, it enhances your immune response to the tumor, even far away from the site where you were injected. So you can see responses like this. You'll see lesions that were injected, but also response in sites where there was no tumor injection. We are offering this therapy now here in Kaiser Permanente. Some of you who were looking for this treatment a year ago may have had to go to other institutions, but we've now internalized this. We're looking to open clinical trials with this agent. For example, one of the trials that is exploring its efficacy when added to nivolumab or pembrolizumab after somebody has progressed on anti-PD-1. Another recent study that got a lot of attention was done by a group that looked at your gut microbiome. They were looking at stool samples and looking at the bacteria that lived in the stool and saw that people with certain bacteria responded better to treatment with immunotherapy, specifically anti-PD-1 therapy, than those who were low in these bacteria, positing that it's not just the treatment itself, but also your own host environment that is playing a large part in how you might respond to treatment. There are trials now moving forward looking at changing your microbiome with just a pill, and we've looked into participating in those as well. Very close to home here, there was a group at UCSF in the lab that looked at mice who received BRAF-targeted therapy. And they asked just a simple question, does it make a difference if you change the dosing schedule? If you give it every day, all the time, as it is prescribed, or if you take breaks in between. Some of you in this room or online may have participated in the S1320 study through the Southwest Oncology Group, where took that concept straight to the bedside, and dabrafenib and trametinib are given either continuously or intermittently to answer exactly this question. So just a very small change in a treatment we already have that may make a substantial difference in outcome. Other novel treatment approaches. In 2017, at the annual oncology meeting in Chicago, 3 abstracts were grouped together that have really excited the field, not just in melanoma, but in cancer immunotherapy in general. basically finding and reporting that treatments active in melanoma, immunotherapy, as well as targeted agents, have efficacy in the brain. This is an area that's has been very difficult to treat for us with other agents because the blood-brain barrier for protection of ourselves and our mental health is not letting toxins or medications usually get up there. But your immune system, BRAF/MEK therapy, does reach this area. And you can see here that the response in the brain is very close to the response in the body for treatments using immunotherapy. Similarly, with drug tablets targeting BRAF and MEK, they've had significant responses in the brain. So very exciting. It really changes the standard in the field. People who previously required debilitating surgery and radiation now may have an option that simply addresses the biology of the tumor just like we treat the rest of your body. And Dr. Kawalczynski touched on this. If you think about this a little bit more, yes, we have treatments to enhance your immune response to the tumor, but should it be given before surgery or should it be given after surgery? The dogma has always been to do surgery first and then do any medical treatment after, and that's because for a long time we just had chemotherapy, and so the side effects of that really precluded wanting to give that beforehand, and it didn't seem to have a good rationale one way or the other. However, with immunotherapy, where you're trying to generate a response in your immune system to a tumor, it seems like it would be better if that were done while the tumor is still there. So this is the study that Dr. Kawalczynski also looked at, ipilimumab versus placebo. We know works after surgery. The nivolumab and ipilimumab showing nivolumab anti-PD-1 therapy to be superior after surgery. But there are studies now that are looking at bringing it into treatment prior to surgery, either in combination or a trial through the Southwest Oncology Group, S1801, which were scheduled to open soon, where they're looking at pembrolizumab before or after surgery for patients who present with advanced but operable disease. So how do we bring these innovative treatment options close to home? This is something we're very proud of. We have the Kaiser Permanente Oncology Clinical Trial Program. It's been a program now 30 years in the making. It was founded in 1989 by Dr. Lou Fehrenbacher, one of my former colleagues, who only very recently retired, and is also based in Vallejo. The cancer center remains, the research center remains in Vallejo today. And it's composed of 70 dedicated clinical trial staff that oversee 21 medical centers across the entire Northern California area. So this is your community here. You know, as you all know this map very well that are here in the room, perhaps not those who are streaming in from far away. So I'll show you that this is the beautiful San Francisco Bay Area, and here is one academic institution, here's another, and here, up here, is the third. And you can see how many other institutions right close to home cover our membership. We're thrilled because the size of our organization really reaches far beyond Northern California. Kaiser Permanente members are connected to those in Oregon, Washington, Colorado, Georgia, even Hawaii. So coast to coast for us really means all kinds of coasts. 40 sites were awarded the NCORE Research Grant and designation from the National Cancer Institute, an arm of the National Institute of Health in 2014. It now unites 7 Kaiser Permanente regions across the country in our participation in ongoing clinical research. 11 million Kaiser Permanente members now have clinical trial access right at home due to this program. A lot comes together to bring these treatments to you. Over the 30 years, we've activated 465 studies. Currently, 484 members are receiving active treatment, and over 4,000 remain in ongoing follow-up. More than 10,000 patients have been consented since the inception of the program. And as physicians, we're proud to participate. So how can I access these new treatment options for my melanoma? Very important, your first touch point should be your doctors and your treatment team. Talk with them about which of the new treatment options makes sense for you. I completely second Dr. Cavalcanti's comments that it's a very individualized decision. I hope you can see how many great tools you have to make the best decision for yourself. In our community, there is a lot of advocacy to bring resources to you to help you in making these decisions. Within Kaiser Permanente, we have the KP Study Search site where you can look up what ongoing trials we have. Nationally, the #1 source will be clinicaltrials.gov, managed right through the NIH. Every trial currently active or previously in activity will be registered here. And they recently changed their search algorithm, and it's much more user-friendly, I'll confirm that. AIM at Melanoma has a clinical trial matching service. And within Northern California, the Association of Northern California Oncologists has a website which will soon go live and having a registry for trials available here in the Bay. Because sometimes, there's a limit to how far perhaps you'd want to travel. Once you're interested and have made a touch point, work with your trial team and don't hesitate. Have them explain to you every step of the process of research enrollment, which can sometimes be onerous. But you can see, I hope, from this the findings we've presented so far, how every patient, provider, caretaker has contributed by trial enrollment to all the advances we have today. So I think it's something to be incredibly proud, and melanoma really keeps setting the momentum for the field. Thank you for joining us today, and we'll talk more later at the Q&A.